This is the Canadian EM Frontline Primer on Intimate Partner Violence Screening. My name is Dr. Kari Sampsel, and I'm with the University of Ottawa and the Ottawa Hospital. The points to focus upon for this particular primer are that the emergency department is a safe haven for many. In the COVID-19 pandemic, many of those who might fall victim to violence at home are currently being asked to stay there in isolation with their potential abusers. During this time, it is imperative that we all be on high alert for signs of violence at home. The current Canadian statistics on intimate partner violence, or IPV, are that women will have a 1 in 6 lifetime risk for IPV, 1 in 3 for sexual assault. As per the CDC, half of the patient population in urban EDs have sexual assault or IPV as a past medical history. IPV is more common than aortic dissections and PEs combined, and it is very lethal since it is highly associated with death by murder. If someone has been strangled, they are 4 times more likely to be murdered in the next calendar year. The following tools have some levels of validity, evidence behind them for screening for intimate partner violence. Of the 2 tools listed below, the PVS is the most commonly used in the ED. The PVS stands for, number 1, have you been hit, kicked, punched, or otherwise hurt by someone in the past year? And if so, by whom? Question 2, do you feel safe in your current relationship? Question 3, is there a partner from a previous relationship who is making you feel unsafe now? This particular screening tool has a sensitivity of 65 to 71%, and a specificity of 80 to 84%. The other screening tool is the STaT3, and it consists of 3 questions in sequence. Have you ever been in a relationship where your partner has slapped or pushed you, thrown, broken, or punched things, or threatened you with violence? This screening tool has a sensitivity of 96% with a 1-point cutoff, and a specificity of 75% with a 1-point cutoff. There's also another tool known as the Danger Assessment Tool for Domestic Abuse. This is a specialized tool that is only used by specialized sexual assault or domestic violence programs or by forensic psychiatrists. This tool is used in female patients presenting to the Emerg after an assault by an intimate partner or farmer partner. It consists of 5 questions. Number 1, has the physical violence increased in frequency or severity over the past 6 months? Number 2, have they ever used a weapon or threatened you with a weapon? Number 3, do you believe they are capable of killing you? Number 4, have you ever been beaten by them while you were pregnant? Number 5, are they violently and constantly jealous of you? The interpretation of this scale is that 3 points or greater presents a high risk of lethality, and there's a calculator linked off the Canadian Frontline Primer website. As for the management of an intimate partner violent patient, coordinating with your local police will be useful in this situation. It should be noted that women's shelter facilities may be functioning quite differently during the COVID-19 pandemic, so it is advisable to involve your social work team to find out what might be the best plan in this dynamic situation. There are 4 main steps of a robust management plan for these circumstances. Number 1 is the disclosure reaction by you and the Emerg. Number 2, safety. Number 3, the injury assessment itself. And number 4, specialist referral. This should be the same despite the pandemic, as most of them are minimal intervention. So let's look at them more specifically. Step number 1, the disclosure reaction. When a patient discloses intimate partner violence to us, our reaction has a massive impact on their morbidity. A supportive reaction has a 6-fold reduction in future PTSD, mood disorders, and substance abuse for the survivor. I teach that thanking people for this disclosure is an appropriate response. Something like, "Thank you for telling me this today. I know that it was really hard. I'll do my best to take care of what you need." This is simple, it establishes trust, and it shows empathy. Please adapt this to fit your style of speech and your pattern of interaction with patients. On average, it's been found that it takes 8 healthcare visits for someone to disclose IPV. So if they pick today, it's a big deal, and we need to take this seriously. Saying things like, "What do you want me to do?" or "We don't deal with that here," are most definitely not helpful. Step 2, safety. These patients need to be in a safe area of the ED, not in the main waiting room, not in an area that is accessible by their abuser. In pandemic times, this is actually a bit easier as everything's locked down. No visitors allowed, and not a lot of people are in the waiting room. But if this patient is waiting for imaging or social work or the specialty team, they should be waiting somewhere that is inaccessible to their abuser. There are many very graphic reports of the abuser showing up at hospitals to finish the job as they are enraged about someone disclosing and seeking care. This step of keeping someone safe within your emergency department can literally save a life. Currently in Canada, a woman is murdered every 6 days, with a greater than 90% of them by partners or ex-partners. Step 3, injury assessment. You should assess these patients like you would any other traumatic injury. Just because it's IPV doesn't mean that the usual rules of trauma don't apply. So look for and document bruising, abrasions, lacerations as you normally would. You are allowed to take photos directly into an EMR if that's your local practice. Just make sure they are taken sensitively. Use the typical decision tools for things like x-rays, CT heads, those kind of practices. A specific strangulation protocol is in development by my team here at Ottawa. A CT angiogram of the neck is the imaging modality of choice for these patients that have symptoms of vascular occlusion, neurological abnormality, or phonation differences. As for the question of how or what to assess, there are 2 major concepts here. Adult IPV is just like child abuse. The signs and symptoms are the same, as well as follow the history. We have the historical features and patterns of injury for child abuse drilled into our heads from day 1 of medical school. It's the same stuff for adults who are being abused. They are just big children in this circumstance. Key features of this include things like stories that change all the time, a history that doesn't match with the injury, major delays in seeking care. Those 3 features are more sensitive in my experience for picking up IPV than any screening tool out there. Remember that the patterns of injury are the same: in concealed areas, multiple injuries at various stages of healing, defensive wounds, injuries that don't make sense with the story that's being told. Finally, let their history guide you. Same as with any other disease entity. If someone says their foot hurts, examine their foot and the associated symptoms. You don't necessarily need to do a full head to toe, particularly if the patient is going to see a specialized service afterwards. Treatment is also the same: wound care, suturing, splinting, casting, tetanus, analgesia. These things we do every day, and it's not any different or any more special with IPV. Medical care always comes before forensic, so don't worry about fixing or covering something up that would be photographed later. We can work that out as a specialized forensic team. Which leads me to step 4, the specialist referral. Most of the Canadian sexual assault and IPV units are running fully during the pandemic so far. If you are unsure of your usual channels, the easiest way, honestly, is to Google domestic violence services and your province or location, and it should come up with the localized treatment centers near you. If you live and work in Ontario, the Ontario Network of Sexual Assault and Domestic Violence Treatment Centers has all of its programs and the areas they serve listed with the contact numbers and information directly on their website. They also have a ton of fantastic resources to help you manage these patients or even for your own education. You can check out their website that's linked off the Canadian Frontline Primer page as well. So what can you do in the emergency department? We recommend that the physician managing an IPV patient call their local center and set up further treatment with them. Navigating all of the legal and social aspects of further safety and care is very complex and very time-consuming, and it isn't really best done in the ED setting, even in the best of times. Plus, the standard for court documentation is very high. Leave that to the professionals that do this all the time. It is important that the doc referring to the specialty service tells the patient that seeing this service does not equal reporting to police. They can help facilitate this, but it isn't a necessity. The specialized treatment programs are not extensions of police services. There should be memorandums of understanding for all hospitals to have access to a specialized program. If someone can't get this information, keeping this patient to see social work to help liaise with social services and potentially police for the forensic part is the next best option. There are some recommended reading, videos, and podcasts that are also linked off of the Canadian Frontline Primer website. Thank you, and thank you for the care of your patients.